So good evening, everybody, and welcome to this symposium at the Charcot Foundation. The title of the symposium is No Evident Inflammatory Disease Activity. So we are used to use the acronym NIDA. Perhaps we should improve it in saying NIDA, because inflammation is what is usually considered within at least NIDA-free. And the question which is posed by this meeting, which is sponsored by Sanofi Genzyme, we thank very much for this important meeting, is whether we have a false sense of security using such an approach. By the way, as you could see, the brain is over the fire, but there is also the spinal cord, which is completely inside the fire, and the activity of the disease, which is not taken into consideration by NIDA. And we know that the spinal cord is a very important part in terms of causing disability in people with MS. So can I have the next slide, please? So this is the faculty which has been gathered together tonight for this symposium. Myself, I'm Massimo Filippi. I'm full professor of neurology at Vita Salute San Raffaele in Milan, Italy. I will just spend a few words to introduce the meeting, and then we will have the much more important comments and discussion by Professor Veronica Popescu from Pelt in Belgium and Professor Bruno Stanco from Paris in France. Next, please. So this is the agenda. As I said, few minutes for me to discuss the re-emerging smoldering disease versus the classical view. So which sort of clinical and imaging data we have to support the idea that there is a smoldering disease going on, a sort of low-grade disease activity, which is, however, widespread, continuous, which causes increased and subtle and difficult to be detected disability in our patients. And then we will move on to Professor Veronica Popescu, who will discuss smoldering disease and clinical progression. And then to Professor Bruno Stankov, the title is Mastering Disease Activity, a False Sense of Security, which is in the title of the general webinar. Next, please. So this is my brief introduction. So why do we believe that there is a smoldering disease which complements or even changes our views on the classical perspective from which we are used to see the disease, and base our assessment in terms of no disease activity on a clinical and imaging assessment. Next, please. So these are my disclosures, and nothing really important related to this short presentation. Next, please. Next, please. Okay, so this is the sort of cartoon from which everything starts when we discuss about MS. As you know, there is different phases of the disease and different phenotypes of the disease. The point that this slide makes is that apart from a clear-cut disease activity, which is detected by relapses in the clinically evident phase of the disease, there is a set of events which are associated to chronic inflammation, axonal loss, which are both then translated into brain and spinal cord volume loss, which is the easiest way to assess neurodegenerative smoldering processes in MS are occurring even before the first clinical presentation of the disease. And anyway, what has been changed in the last few years is that neurodegeneration and smoldering disease starts at least from day one of a clinical presentation of the disease, if not even before. And this is an important part of the story, which has not been much assessed in the past, and which is not yet been translated into ways to monitor disease evolution in people with MS. Next, please. On the other side, however, we know that patients with MS continue to accumulate disability and brain volume loss along the course of the disease. This is taken from the Swedish register, showing that as long as the time goes by, especially after a few decades, people, despite being on treatment, continue to progress to secondary progressive MS. And it is particularly evident already 10 years after disease onset, and it is progressing over time in a pretty fast pace. These are instead the data taken from MR, which readdresses this point. We might have stable, no relapsing, no worsening people, but they do have continuous loss of brain volume in terms of measuring brain atrophy on T1 weighted scans. So there is clinical data as well as MR data showing that despite our inability to detect any disease activity, the process goes on and causes tissue loss. And tissue loss in this case, it is in the brain and likely in the spinal cord, which are which are very important for human life. So we should be able to protect, in addition, over disease activity, also these destroying aspects of the disease. Next, please. So this is why recently, there were introduced measures to assess not only relapse-associated worsening, so what is disability which remains after the clinical relapse, but also progression independent of relapse activity, PIRA, which is somewhat a clinical measure of smoldering disease evolution in multiple sclerosis. Next, please. And of course, this is also should be translated in MR, because we usually assess one axis, which is the with NIDA-free, which is the activity axis in terms of relapse rate and the presence of active lesions on MR. But we have also a neurodegenerative axis, which we have neglected quite a lot in the past few years, and that we needed to readdress in a very fast and complete way now. So this is just two examples, again, taken from one from clinical and one other from MR aspects. So in clinical terms, even if you have people which are for 2 years, this is work by Prosperini in Rome, with NIDA-free negative, they still continue to accumulate, even after treatment initiation, disability, which is also related to progressive increase of disability independent of activity. And on the other side, we should also consider that in people that are even clinically stable, we do have data showing that there is even along a short period of time, such as 1 year, progressive loss of tissue in this critical part of the CNS. Next, please. Of course, there is evolving science related to MS pathogenesis. This is a very complex table which will be readdressed in a better way by Professor Stankov later on. This is just to make the point that there is emerging views also from basic science that there is chronic smoldering inflammation in people with MS, which is compartmentalized within the CNS and which involves innate immune system. So additional data showing that we should readdress our classical perspective on MS to consider this smoldering progression, which is essential for accumulation of disability later on in the course of the disease. Next, please. And so I stop here and hand over the presentation to Professor Veronica Popescu from the University MS Center in Pelt, Hasselt in Belgium. Thank you very much, Veronica.
Thank you very much, Professor Filippi. I will do my best to continue this presentation in such an interesting and scientific way. We will look actually from now at the clinical progression, at the clinical aspects of smoldering disease. Next, we will start first with my disclosures. And then on the next slide, we will just have a look at the way that our understanding of MS has changed in the last couple of years. And actually, we started looking from only at the most impressive focal damage illustrated by lesions and also by relapses. And we realized that the loss of function on the physical level as well on the cognitive level are not just due to relapses and lesions, but also to this chronic damage that we call smoldering MS. And we call this smoldering MS because it's like a fire indeed that is not burning with a high flame, but it just keeps on burning, and it leads to actually neurodegeneration. And this neurodegeneration we see through brain atrophy, and it will eventually lead to disability. And when we look at the next slide, we will actually see a clinical picture that we probably see very frequently in our daily practice. So we look at this case of this lady who is 38 years old, and she has been treated for a while with DMT. She takes it very well. And there are no new lesions on her MRI, so we are very happy with that. There are also no new relapses, and her EDSS is being stable. So, of course, we can only call this a very stable disease. Not only is she being stable, but she's also running, and she stays employed. So that is a very good thing, right? But when we look at the next slide, we can actually ask the question whether she's really stable. Or is there something more going on here? Please, next slide. What if we would ask her? So she has now been free of new relapses and new lesions for a while. And she agrees that she's happy that her disease-modifying treatment is actually controlling her disease because she has no relapses. But she notices a very slow but still a deterioration. So the half marathons that she used to run are now not possible anymore now. And also she cannot keep up the pace of her training group. Of course, as a physician, we have to document things very objectively. So we are going to say that she's running 3 miles a day, which is very good, right? It's 5 kilometers. So that's a very nice distance. And especially for somebody who's running every day, we would be as neurologists very happy. But there's still a little bit more, because she says, well, I do make more mistakes at work. I still keep my job. It's not that bad. But I start forgetting things, and I get more easily distracted, and I cannot concentrate as well. And she indeed attributes this to getting older, which is something that we sometimes hear in the clinic starting from a very early age, that people will attribute this kind of deterioration to getting older. And she has also difficulty driving. Difficulty driving is something that we see very often because it is a complicated activity, and especially nowadays with all kinds of inputs that we have to integrate, it's getting a little bit, it's getting even more difficult than it was. But still, she is able to drive, and she is able to keep her driver's license, although in this case, she probably does not drive long distances. So her life, she will have to adjust her life to this new state that she is in. Next slide, please. She appears clinically stable, but there is something going on. Next. What do the patients think very often? So some of them are actually wondering whether it is a real phenomenon that they are experiencing. Like the lady already said, she attributes this kind of deterioration to just getting older, so to something else than just her MS. But other patients do think that there is something going on, and they are frustrated because we don't, by telling them that they are stable, even though they feel that they are getting worse, we are not validating something that they feel and they experience in daily life. But on the other hand, other patients are really very worried that they are getting progressive MS. And most people are really very, very scared of the idea of being labeled progressive MS, because progressive MS is being equaled to actually being in a wheelchair and the end stage of MS. So people would rather not hear the word and just not think about it. Next. What are these invisible symptoms of MS, like we call this gradual deterioration? What can they lead to? I mean, it's not, there are very objective measures that we can see, but it's also non-objective measures, it's subjective measures. And some of them are very important and adding strain to the patient's social life, but also to the work life. I would like to attract your attention to this graph on the right side, and it shows how many people actually suffer from a low energy level. It is really the vast majority of patients with MS. And something that we will also see on the next slide is actually the fact that it will affect the ability to keep their job. So lots of patients with MS, can we please go back to the previous slide? Lots of patients with MS will have problems keeping their job, and also their ability to exercise and to physically function. Also very important is the fact that their financial well-being will be affected, and their career, as well as their family life. Now, if we can go to the next slide. We can actually see that this is something that we should explore in the clinical visits, so during our consultations. We can ask the patients also how they are doing at work, and sometimes we will get very eloquent answers in the sense that I cannot cope anymore with a workload, and this is something that a couple of years ago was not a problem for me, but nowadays I cannot keep up, and I notice that I have to work a lot longer than my colleagues in order to complete my tasks. And as you can see, the rates of unemployment in MS are actually very huge. Also, people do report that they drive a lot less due to either the fact that they have difficulty integrating these kind of impulses coming from everywhere, and so they reduce their driving, which means that they are also losing a lot of their independence, especially in countries where people are very dependent on driving. We know that MS patients do get involved in more car accidents. So this is also not only a problem for their independence and for their driving, but also a problem for their physical well-being. Next, please. Now, it can be very subtle, the way that smoldering MS appears, because what we know is that this type of slow but gradual worsening appears from very early on in the disease. And it's due to a smoldering MS, and it is independent of relapse activity. And it is actually a forebearer, it is actually a pre-state of progressive MS. So it takes a while until the patients are labeled secondary progressive MS. And it is very important to be ahead of the curve. And if in the future we will have medication and interventions that can stop this smoldering MS, it is very important to be on time and not to wait until the deterioration is irreversible. Next slide. Also, smoldering MS is associated with disease duration, of course, and with a number of lesions, but very importantly, with a brain volume, with a total brain volume, and also with a gray matter volume. What you can see here is this study where they look at the progression independent of relapses, which is another term for smoldering MS, and also at relapse-associated worsening. And the relapse-associated worsening is mainly associated with new gadolinium-enhancing lesions, but the progression independent of relapses or smoldering MS is actually mainly associated with these MRI parameters. And the gray matter is very, very important because, as we can see on the next slide, it is also not just the atrophy of the gray matter, but also the gray matter lesions and the number, the accumulation of gray matter lesion, which is very, very predictive of the onset of secondary progressive MS. So of the duration to secondary progressive MS. So it is very important to look in the cortical gray matter for changes. Next slide. But we can also look in the white matter already. And although this is a lovely study at 7 Tesla, and it gives us very, very nice images, we can see already, we can look at these paramagnetic rim lesions. And these are lesions which are found in most of the patients with MS, but especially in secondary progressive patients. But we can also find them very early in the disease. So in people who have CIS or early relapsing remitting MS. What we call these paramagnetic rim lesions, they are also called slowly expanding lesions or cells, and they are also called smoldering lesions by association with smoldering MS. So these are the lesions which are chronically active, which are there is still activity inside of them, and they are slowly but steadily growing, even though there are no new lesions appearing on the MRI. It's these old lesions which are still very active. Next. These slowly expanding lesions are associated with progressive demyelination, and this is something that we can see on more advanced imaging techniques like diffusion tensor imaging, and as well as magnetization transfer ratio. And with both of these techniques, we can see that the myelin content is lower and the tissue integrity is getting worse. And both of these measures of demyelination are more pronounced in secondary progressive patients. Next. Now, what do we think happens in smoldering MS is these chronic active lesions, which are very important, associated with clinical outcome and also with brain atrophy. And Professor Stankov will actually go into a lot of details and tell you lots of things about these microglial activations and the meningeal inflammation. But what is very important to realize, next slide, please, is that it is important now to change our view of MS treatment goals and go from just the very visible, the very obvious MRI activity and relapses visible through NIDA-3. And going through also bringing into it the brain volume loss, but go even further towards managing MS in order to have no marker of axonal damage and no inflammatory markers in the tissue. And of course, we will have to use more advanced techniques and new biomarkers. Thank you very much.
So thank you very much. It's now my turn. I'm very happy to go on and discuss with you what could be some of the mechanisms that underlie this smoldering aspect of the disease. Next slide, please. You can see here my disclosure, which are globally not related to this talk. Next slide, please. So, as it has been just discussed before, we are now evolving from a classical established view that consider the peripheral adaptive immune system and its reaction as a key driver of the disease towards a novel view which consider the chronic smoldering inflammation as a major component of the progressive stages of the disease. And this chronic smoldering inflammatory component may be compartmentalized in the CNS and involve predominantly, not only, but predominantly the innate immune system, as we'll see just after. Next slide, please. So, as a consequence of this renewed view, we'll have to rethink about novel therapeutical targets to cure or at least to reduce this smoldering process. We know that in the CNS, the presence of pro-inflammatory factors and microglial cell activation is involved in oligodendroglial damage and demyelination. And this results finally in axon damage and degeneration and cell death. And interestingly, in turn, this cell damage will exacerbate the inflammatory process in the CNS. And this make the reaction to enter into a vicious cycle that take part in the progressive phase of the disease and to the neurodegenerative component. Next slide, please. As it has just been discussed before, one of the paradigmatic markers of this moldering process in the disease are the chronic active lesions. And they have been described first by pathological investigation, and they are then being identified by advanced MRI techniques and are characterized by their peri-lesional rim and by their slow expansion with time. On pathological examination, those chronic active lesions are characterized first by an accumulation of adaptive immune cells that are mostly restricted to the perivascular space and that diffuse very minor diffusion with a very minor diffusion in the parenchyma. And these adaptive cells may be CD8 T cell, CD20 B cell, or plasma cell. Interestingly, in this lesion, there is no major blood-brain barrier damage as attested by the lack of fibrinogen deposition around the vessel. And the second key feature of this chronic active lesion is a peripheral activation of microglial and macrophages cells that make a rim at lesion edge and that characterize chronic active lesions. Next slide, please. A second illustration of this smoldering process is illustrated by what happens in the meninges of patients with a chronic disease. And we know that in this meningeal space, there is accumulation of CNS lymphocytes, mainly B cells, but also some T cells or some plasmocytes. And this accumulation of cells that sometimes organize what we call follicules in the meninges is facing to damage in the cortical surface. And this damage consists in demyelination and neuronal death. Interestingly, this meningeal inflammation may mediate this cell damage through the activation of microglial and macrophage cells here again. And the mediators that may make the link between meningeal inflammation and tissue damage in the cortex may involve pro-inflammatory cytokines, autoantibodies, or some mediators that are found in the CSF, such as ceramide, semaphorin 4, or some heme degradation products. And all of these products could induce some damage. Interestingly also, antibodies, which are not specific for antigen, but that can bind to microglial cells through Fc gamma receptor, could also activate microglial cells. Next slide, please. So we see that these innate immune cells are involved at quite all stages of the disease, as early as the active lesion, acute active lesion, or subacute active lesion, where microglial and macrophage activation is found through the lesion and accumulate mostly at the more active place of the lesion. And in some lesions only, this chronic activation of microglial cells stay at the rim of the lesion, at the edge of the lesion, and disappear from the center of the lesion, characterizing the chronic active lesion we have discussed just before. Next slide. Why such persistent activation of microglial cell persists in chronic active lesions remains a mystery in the disease that should be unraveled if we want to find some active therapies that fight against those chronic active lesions. Looking at what we have learned from pathological studies, it was shown from either immunohistochemistry on pathological sample or on transcriptomic analysis from those lesions that they are characterized by an accumulation of pro-inflammatory cells that could express some pro-inflammatory markers such as the CD163 shown here, colocalized with monocytes and microglial cells. And there is a reduction or a disappearance of more homeostatic or regulatory cells, as attested here by this CD206 marker. And this dysregulation between the two aspects of microglial activation, the regulatory homeostatic on one hand and on pro-inflammatory on the other hand, may explain in part why this pro-inflammatory reaction stay in the edge of those lesions. And interestingly enough, this pro-inflammatory reaction is characterized also by the iron uptake and ferritin expression. And this is what we can detect using some advanced MRI sequence, such as susceptibility sequence or QSM. Next slide, please. So downstream to this pro-inflammatory microglial activation, several cascade of events may lead to cell damage and cell death. One is the oxidative burst, and this has been very well shown by the Hans Lassmann team on pathological samples. And this oxidative burst may be reflected by the overexpression of the pro-inflammatory marker and ADPH oxidase. The second interconnected mechanism is the oxidation of some target within the cell, either in neurons, but also maybe in other cells such as oligodendrocytes. And this can be visualized as oxidated DNA or oxidated phospholipids in this cell that is an intermediary stage before cell death. And a third key component is the energy dysregulation, and that involves the mitochondria, especially in neurons, but also in other cells. And in chronic active lesion, it has been shown that some mitochondrial deletion or mutation could accumulate and could participate to this energy dysregulation. And all these mechanisms finally contribute to cell death and neurodegeneration. Next slide, please. So we have seen that in this smoldering process, the immune cell, partly the adaptive immune cell, but also a lot the innate immune cell are strong contributors. And you can see that there are several pathological drivers that are interconnected with this smoldering inflammatory process, starting from demyelination and involving some intracellular pathway with oxidative injury, mitochondrial damage, and so on. So to visualize and to assess each of these mechanisms, we'll have to develop and apply more advanced imaging tools to quantify each single process. And we have seen that as the neuroinflammatory component has a central role here, several imaging methods could visualize this neuroinflammatory component, such as PET with TSPO, but also MRI that has been discussed before with this peripheral rim on a chronic active lesion or their smoldering aspect. Next slide. So, as this neuroinflammatory component plays a central role in the smoldering component and is closely interconnected with the neurodegeneration, there have been investigated about novel targets that could be of interest to reduce this smoldering aspect. Let's see the next slide, please. One of the most popular one to date is the Bruton tyrosine kinase pathway. Bruton tyrosine kinases are small kinases that regulate several aspects of the adaptive and innate immune cell signaling. They are expressed both by B cell, downstream to B cell receptor, and they are connected to calcium mobilization and phospholipid C gamma. And this enzyme is involved in maturation of a B lymphocyte, proliferation of B lymphocyte, and their cytokine production. So inhibiting BTK could reduce this aspect on B cell. And another advantage of this target is that it's strongly expressed by innate immune cell downstream to FC gamma receptor, and mobilizing, activating the same cascade. This pathway is involved in innate immune cell activation and liberation of pro-inflammatory factor. So inhibiting Bruton tyrosine kinase could lead to a reduction of B cell activation and of innate immune cell activation, both phenomena being involved in the smoldering process of the disease. Next slide. Interestingly, recent work performed and presented at the American Academy, but not yet published, have demonstrated that this target could be really relevant in progressive MS, as it is regulated in chronic active lesion, especially at their age, and either by quantifying protein or a messenger RNA, it was found that BTK was overexpressed in MS tissue. Next slide. A second target of interest, which is at the more early stage and which is quite a transversal target in neurodegenerative process that involve a neuroinflammatory component, is the RIP kinase 1. RIP kinase is a small enzyme involved in several cell processes, but the 2K process is the first to be involved in a cell death pathway called necroptosis. And necroptosis has been shown to involve oligodendrocyte in the cortex of patients with MS with another expression of RIP kinase. And the second very important process is that once a cell undergo necroptosis, it will secrete some pro-inflammatory factors that will in turn exacerbate and maintain the neuroinflammatory component. And this may partly explain the vicious circle that I've discussed before to maintain a persisting neuroinflammatory component in smoldering disease. Next slide. The third target of interest could be the colony stimulating factor 1 receptor, which is specifically expressed by innate immune cell and which is involved in the several aspects of the activation of this immune cell, such as proliferation, survival, chemotaxis, and liberation of pro-inflammatory factor. And it has been shown that this CSF1 receptor pathway was upregulated in the CNS of patients with a progressive phase of the disease. Next slide. Lastly, but not least, there are maybe other targets, but the NLRP3 inflammasome signaling has also been shown to be upregulated in neurodegenerative diseases, and especially in MS. And it is really important as a pro-inflammatory signal, and reducing this NLRP3 inflammasome, which is quite specific to neurodegenerative disease, could represent for the future an interesting and promising target. Next slide. So if we want to assess all these new targets in a therapeutical trial, we'll have to develop and apply imaging tool able to quantify the neuroinflammatory process. And this can be MRI, as we have seen, with either phase or susceptibility imaging, quantifying a progressive chronic active lesion, but also TSPO PET, which has the potential to detect all active lesions, whatever they are enhanced or not enhanced by gadolinium. And it has been able to identify in patients with MS a large number of lesions that are finally active on PET that were not detected on MRI. And beyond imaging, also, of course, biomarkers will be of great interest to quantify and monitor these processes. Next slide. So to conclude, we have seen that if we want to monitor better this smoldering compound, we'll have to add to our MEDA matrix another dimension with CSF or biomarkers in the blood, but also maybe involving advanced imaging. Next slide. Thank you very much for your attention.
Thank you very much, Bruno, and thank you very much, Veronica, for the two nice talks, which are now open to discussion. We have still, unfortunately, just 5 minutes. So the audience, don't be shy and ask questions if you wish. Perhaps I could start by saying that, of course, we do have a full sense of security with NEDA, as you have pretty well shown. And the questions to you to start discussion is, it is clear there is a smoldering progression in MS from any perspective you see at this disease. So the question to you is whether, how many people do you think that are experiencing smoldering activity despite the phase of the disease, despite being treated with the classical treatment for MS? So in my view, I would say virtually all. But so this is a major phenomenon. It is not just present, it's present perhaps in all patients. So I would like for you to give to the audience a sense of the amount of this phenomenon in multiple sclerosis. So perhaps you can start with Veronica, ladies first, and then to Bruno.
I would have been more optimistic and say 70 to 80%. Whether you can call this optimistic in this context, it is indeed very common, and it is. I think that most of the time, whether we don't see it because we don't ask about it, and the moment that we do realize it, it's already too late when the patients are already secondary progressive.
Bruno?
Yes, I would agree that this is a quite common feature of the disease, but with a different intensity regarding the patient. And some patients will have only a very minor smoldering component and they will evolve very slowly. Whereas some other, we do not know exactly why, but they will have a very strong smoldering component and they will have either a quick PIRA or quick progression during the secondary phase and more quick atrophy and so on.
But coming back to the point that Veronica did, that if we wait too much, we are likely to be late. So, and given the fact that I'm a bit less optimistic, but let's assume it's 80% of people. So I would tend to treat them as early as possible, since perhaps if you stop the disease very early, we then prevent also these additional aspects, less classical aspects of the disease. So I was wondering whether you do believe that we should treat early, this is pretty clear, but also high efficacy in order to prevent this situation that also we might prognosticate at the very beginning with classical MR measure. It is then very difficult to understand what is going on later on in the course of the disease. So, and whether you wish to have data from regulatory trials showing that the drugs that you are likely to use is also able to affect brain atrophy, for instance, in order to have the easiest proxy to this phenomenon.
Ideally, we should have that, and indeed you are right, brain atrophy is something that is already being collected within clinical trials, so these data we have, and maybe it's not ideal, and as you could also see during the presentation, it's not a one-to-one correlation, but it is the best that we have at the moment.
Yes, I agree that we should treat early because, as we described, there is this kind of vicious circle that may amplificate with time if we let the thing, happens. So, of course, atrophy is one of the best measures as it is available and everybody can use it. But it takes time to measure atrophy, and maybe implementing some biomarkers in the blood and maybe also some advanced tools that may detect, some active lesions that are not seen on the classical MRI may help, to really assess globally this smoldering process.
Thank you very much. Perhaps we can have the last slide because our time is going over. So this is a summary take-home message slide. So first of all, let me thank again Sanofi Genzyme for supporting this important event, and Veronica and Bruno for doing a great job both with the presentations and then with the discussion. I think that the take-home message is, I could summarize this long slide by saying that, of course, there is smoldering activity or smoldering progression in people with MS that can be seen by from basic science to MR to clinical assessment. That we should be clever enough to consider that what we don't see, it might exist anyway. So we should be clever to implement new measures to detect such an important component of the disease. And I think that just using NIDA-freeze, of course, I think we responded pretty well to our initial question. Is really not sufficient to be really on the safe side when treating people with MS. And then we ended suggesting that there are already treatment to counteract this important aspect of the disease, and there are additional on the pipeline that might help our ability to control the disease even more in the future. So thank you once again for the presentations and for listening to us, and to Sanofi Genzyme for supporting this event. Have a nice evening.
Thank you very much.
Thank you.